Yeah, we're going to address a difficult but unique fracture pattern, which primarily highlights a displacement of the dorsal lunate facet. Realize that this represents a threat to both the radiocarpal and radio-ulnar joint articulations. How to approach this? There are several approaches that have been described, and we can look at that more clearly with schematics. Orbe described an approach where, from a volar side, once the fracture has been identified, the proximal shaft of the radius is pronated to be able to visualize the joint and the displaced dorsal articular components through the fracture site. Once that's done, it's temporarily held in place and then supported with a volar plate. The second approach, and one favored by traditionally many surgeons, is a direct dorsal ulnar approach, addressing the dorsal lunate facet as a component part of the fracture itself. Third is to reduce the component by a volar approach and then through the plate manipulating the fracture fragment, and almost an indirect manipulation of the fracture fragments. And a last approach is using a volar approach and then a distal radius reduction clamp that can be applied with one ball tip into the plate and one into a radiolucent sleeve that sits on the dorsal lunate facet, using compression to bring the fragments together. 61 patients in the ICUC database were identified as having a displaced dorsal lunate facet. This is out of 191 consecutive fractures that were followed. Here is the most relevant part of this scientific study. We're going to show you the problem, we're going to show you the technique, but we're going to quantitate the adequacy of the reduction by virtue of comparing a post-op CT scan in a coronal section to the pre-op CT scan. There are many ways that people have described in treating these, but rarely has anyone consecutively documented the accuracy of the reduction. These studies have been reviewed and by a Swiss individual, Andreas Meissner, and show that they are clearly depicted from the start to the finish. There's no data that are omitted. There's no cases that are omitted. And so this is a very honest depiction of the identification of a particular problem and their treatment. The outcome measures are radiologic for the most part, looking at several component parts. One is the displacement in the axial and sagittal plane of the articular surface, that's the sigmoid notch, and whether or not there's an impaction or axial step-off in the joint surface as well. And finally, whether or not there's ulnar subluxation. Preoperatively, this case has been documented here, and then the postoperative evaluation, viewed by several surgeons independently. The axial coronal CT is shown here, showing the gap and the step-off and the relationship of the lunate, facet, and sigmoid notch to the ulnar head in this CT scan, and the post-op CT scan with the same measurements. And this is the long-term follow-up of this patient. All were treated with only a volar approach. Here's another patient, and we have a gap on the preoperative image CT scan and appreciate the reduction. Here's the preoperative CT scan, wide displacement disruption of the sigmoid notch, the displaced lunate facet, the relationship of the ulnar head, the alignment and question of impaction of the sigmoid notch and lunate facet. And here's the postoperative CT scan, revealing a smoother lunate facet, a clearer relationship of the ulnar head in this sigmoid notch, and in several views revealing this. Long-term follow-up without any residual radiocarpal or radio-ulnar dysfunction. Another case with a rather substantial 4 millimeter gap and step-off, and a reduction considerably better, although not perfect in all views. But here we see the preoperative impaction and gap between this fragment and this fragment, relationship of the ulnar head, which is off-centered in two views, And here's the postoperative CT scan. The height and dimensions of the sigmoid notch have been restored. Relationship of the ulnar head to the sigmoid notch restored, and the loss of that impaction gap present. And here's the functional follow-up. One more example of each of these parameters improved to a large degree in the post-op CT. This gives you a very nice picture of this isolated lunate facet, the offset of the ulnar head to the facet, the offset in the regular x-ray, and the sigmoid notch that's shown, and the post-op CT, which shows a realignment, restoration of the radiocarpal radio-ulnar joint. All this reduction done through a volar approach with the enhancement of reduction by this all-tip distal radius clamp. Here's another example, and note the major displacement in several planes, and substantial correction, although not complete. And here's the major gap and step off, the shortening of the two pieces together. Here's the big gap here, see that, and an improvement, still some gap, but the dorsal volar alignment is near anatomic and the ulnar head is restored. So we see that the ulnar head restoration is intact. We see the reduction of the sigmoid notch. Dorsal lunate facet is near anatomic. And notice the screw that extends into the dorsal cortex. These are screws that are locked into the plate. So the question is, and remains to be discussed, whether or not it's critical to get a screw in that dorsal component, whether or not it functions like a screw to bring it into better compression, whether or not having a screw go through the opposite cortex creates a risk of irritating the tendons. So many people would suggest that once you put the screw that's locked into the plate, it no longer functions like a screw, capturing and bringing the opposite cortex into the near cortex, i.e. compressing it. So we don't know the answer from these studies, except to say that these patients did not have tendon problems later and had an excellent reduction and hold of the piece as they rehabilitated. Let's look at another example that had a displacement. Here's the dorsal lunate facet. Dorsal lunate facet. Ulnar is a little off-centered, and we now see this in a much better alignment and a much better contour of the sigmoid notch. Long-term follow-up. It's a very large impaction and a gap, reduced nearly fully, but still some residual ulnar subluxation, as we'll see. Big impaction, gap, the height is displaced, and the reduction we see here. Still a little bit of an impaction, but otherwise a functional sigmoid notch. There's another example. This is very minimally displaced with a good alignment. I also want you to highlight something that is very important, and it's important in the fundamental concept of the ICUC app and the database. And that is, in every single case, while we're looking specifically at in this case, the lunate facet dorsally, we're looking at comparing it on pre and post-op CTs to the adequacy of reduction using known criteria, and looking at the placement of the implant, and in this case, whether or not screw is important to get into that fragment. The ICUC app and the data collection of these 61 cases is available to anyone, and the individual can go to see the initial assessment, treatment, outcome all the way through on every single patient, every single case of the 61 cases. This is very important in today's world, where with electronic submissions to journals and whatever, we see more and more databases mined from large studies where the patients are never seen, nor are any direct patient outcomes documented. We highlight also the use of this reduction clamp that is particularly helpful in this type of fracture.
With the belief that more transparency in the practice of medicine will enable substantial progress, ICUC is launching a cutting-edge app to improve learning of surgical procedures in orthopedics. The app gathers complete, unchanged, and consecutive series of surgical interventions. Independent orthopedic surgeons record the interventions from pre-op to functional result to ensure complete recording, including surgical shortcomings. Download the app from the Apple App Store and access for free to a broad library of orthopedic case studies. Try ICUC app and discover a new learning experience.